Great. Thank you so much. Can you all hear me in the back? Yes? It's a privilege to be here. Thank you so much for the invitation to participate. I will be covering the next 2 hours. I'll try to keep you awake a little bit while we do this. And the first topic will be dual energy CT. I'll give you a little bit of background on the physics, really, of how dual energy CT works and how it can add clinical value in our imaging. First, I'd like to ask, does anybody here have any experience using dual energy CT? A little bit. Good. So I will go to some of the basics. These are some disclosures. The one that's relevant here is our institution receives some grant funding from Siemens on this topic. So I'll explain some of the key requirements of dual energy CT acquisition and show you a little bit about how the different manufacturers do this. I'll talk about some of the post-processing techniques that are relevant in clinical practice, and I'll try to show you some different scenarios where I believe dual energy CT can add clinical value. So for starters, this is our conventional CT imaging with a single X-ray spectrum. And here what I want to make sure everyone understands is the difference between KV or KVP and KEV. So if you recall, KVP is the voltage that we place across the X-ray tube between the anode and the cathode. We accelerate electrons through a vacuum to 120, in this case, KEV. So we apply 120 kilovolts across the X-ray tube, and this accelerates X-rays to 120 kilo electron volts KEV. Thank you. Of course, when the X-rays hit the cathode, only some of this energy is released in the form of X-rays, the rest is released in the form of heat. And so we end up with a spectrum, a broad spectrum like this, where the maximum energy of any X-ray is 120 keV, but we have a broad distribution below. And this will become important a bit later. What we're looking at in taking advantage of in dual energy CT is the fact that different materials absorb X-rays differently as a function of X-ray energy. So if we look in the top here at this vial of iodine, as we all know, iodine blocks more X-rays at low energy. So as we go to lower KV, we see higher Hounsfield unit values in the iodine. Similarly, we see the same effect in bone, but we see the opposite effect in fat. You see here that as we go to lower energy X-ray spectra, the fat becomes darker. That's the opposite direction. On the other hand, most other materials in the body have very similar Hounsfield unit values regardless of the X-ray energy that we use. So another way to view this is in a graph like this, where we have here the Hounsfield units at low KV, here the Hounsfield units at high KV, and as you know, water and air are calibrated to always be at 0 or minus 1,000 Hounsfield units, no matter what X-ray energy we use. On the other hand, iodine goes to higher Hounsfield units at low energy. Bone does the same sort of thing, but with a more shallow slope. Fat, I already showed you, ends up at lower Hounsfield units at low KV compared to high KV. And so you can see now that we might be able to differentiate these different materials if we can take advantage of these properties. So what do we need in order to do dual energy CT? The first thing we need is for the materials to have fundamentally different X-ray absorption behavior. And the other thing we need is different enough X-ray spectra to be able to demonstrate that behavior. So for example, if I have 140 kV here and 139 kV here, I'm not going to be able to differentiate these materials. So I need to have good spectral separation to acquire data with different enough X-ray spectra to be able to demonstrate this underlying difference in material properties. Here's how that looks. If we have X-ray spectra at different kV values, we can see these spectra look like so. If I pick two of these, in this case 100 and 140 kVp, you can see that there's a lot of overlap between these spectra. There's a very slight difference in the mean energy of this spectrum compared to this spectrum, but this is not good spectral separation. So what can we do to improve spectral separation? We can go to a wider pair, 80 kV and 140 kV. you can see that there's better separation, although there's still a lot of overlap between these spectra. And the other approach we can do is if we put a filter, in this case a tin filter, in front of this high energy spectrum, we can absorb a lot of the low energy X-rays from that spectrum, and we can improve spectral separation in that way. So knowing this, let's talk about how the different manufacturers perform dual energy CT. This is the GE approach. They do rapid kV switching, so that as the gantry is rotating around the patient, every other projection is acquired at a different energy. We have 80 kV, 140 kV, 80, 140, 80, 140, very rapidly around the gantry rotation, so that we have, again, every other projection is acquired at either low or high kV, and we have enough information acquired that way to be able to understand how the materials inside behave. This is the Siemens approach. This is their dual source approach. In this machine, we essentially have two CT machines packed into one CT gantry. So we have two X-ray tubes, one operating at low kV, the other operating at high kV. Each of these has a matching detector array, and so we simultaneously acquire the low energy and the high energy information, and in this way we have what we need for dual energy CT. And finally, the Philips system, which is the latest one to come to market, has a detector-based system where they have a single X-ray tube, but we have a detector split into a superficial layer that preferentially absorbs low-energy X-rays, and what remains is preferentially absorbed in the bottom layer, which is the high-energy X-rays. So in this way also, we have data acquired simultaneously at both low and high energy. All of these approaches work. There are different pros and cons to the different manufacturer approaches, but they all can work for dual energy CT. So now that we know how the data is acquired, let's talk about how the data is post-processed to be able to use this in our clinical work. The first method is called two-material decomposition, and in these algorithms, the assumption is made that everything in the image is composed of only two materials. We can pick a variety of different options. These are some of the material basis pairs, they're called, that are most commonly used. So we can either separate things into those that behave like the photoelectron effect and those that behave like Compton scatter, or we can split into iodine and water as another very common pair. And then what we do is each material is decomposed into contributions from these two basis material sets. And what this means is that if we pick a material that is not similar to one of these, it shows up in both sets of images. So calcium is the classic example that appears on both an iodine image and a water image because its behavior is not adequately captured in just one or the other. And any other material can be generated by appropriately combining the information that we have decomposed in this way. So here's an example from, this is from Duke, a colleague at Duke, showing an iodine selective image and a water selective image. So this is an attempt to eliminate the vast majority of the iodine from the image, which appears here. You'll notice that the calcium in the spine, as I mentioned, shows up in both sets of images. Two-material decomposition. The next thing that we can do is called virtual monochromatic or virtual monoenergetic imaging. And here what we do is, by knowing how these different materials behave with low and high energies, we can simulate what they, how well they would absorb X-rays at specific fixed KeV values. Now this is imaginary. We cannot actually create X-rays of a single KeV value, but knowing how they behave at high and low kV, we can calculate how we would expect them to behave if we were magically able to produce an X-ray source of a single energy. So here we have a traditional image, and I'm showing you a lesion at the bottom of the kidney here that is hyperdense compared to fluid. We're not sure if this is a cyst or if this is an enhancing mass at this point. If I put regions of interest on these different portions of the image, I can see that the parenchyma, which contains a lot of iodine, shows this very characteristic increase in Hounsfield units as we go to lower KeV values. You can see that the lesion that I'm interested in stays very flat. So we know that it does not contain iodine. We know that this is essentially a benign, non-enhancing, hyperdense cyst. And if we look at the adjacent fat, as I mentioned, fat has this characteristic decrease in Hounsfield unit values as we go to lower X-ray energies. What we can also do then is we can pick a KEV value and we can say, what would this image look like at this low KEV? And what I hope you can see here is that we've managed to make the iodine much brighter at this image to the right. Similarly, if we pick a very high KEV value, you can see that we've thrown away most of the enhancement from our iodine. And this is simply because we know how that material behaves. We can create an image that simulates how it would look at a single KEV value. One of the places where virtual monochromatic images are used most commonly is for beam hardening artifact reduction. You can see here that as we increase to higher and higher KEV values, we eliminate a lot of the streak artifact next to this medullary rod, and we can actually now see the bone implant interface much better at this high KEV image than at this low KEV image. So this is one of the areas of interest for this technique. The other thing we can do, as I pointed out to you, is we can use it to enhance the iodine content. So here in this contrast-enhanced head CT, we can see that the iodine is made much more apparent at low KEV. This is often used to salvage a CT angiogram where our contrast infusion didn't work so well. We can really bring out that iodine content. We can also use it in some situations to intentionally reduce the amount of IV contrast that we give, and we can create a beautiful CT angiogram with a small amount of iodine compared to what we would normally use. The other thing that's interesting here is look at the gray-white differentiation here. You can see that at low KEV, this is now 45 KEV on a Philips image that I borrowed from a group in Texas. You can see that we see the gray-white differentiation much more clearly than we do on our conventional image here. So this is another technique where this can be helpful. Now the next category that I'll move on to is 3 material decomposition. Here what I'm showing is Hounsfield units at low KV versus high KV here. In this technique, we pick a basis material line, in this case, defined by the usual Hounsfield units of fat and organ parenchyma. Often liver parenchyma is used for this portion of the curve. And as I add iodine to these materials, we have this very characteristic increase that I mentioned, where we have greater increase in Hounsfield units at low energy compared to high energy. So iodine has this very characteristic and known slope. The more iodine I add, the farther I move in this direction. And so what this means is that everything that's shaded in blue here can be attributed to iodine being present within the image. If I then take a voxel, I can therefore decompose it into the amount of iodine and into a corresponding virtual non-contrast image. So this is the virtual non-contrast image where I have subtracted out the iodine from the image. And this is the iodine image where now in color I'm demonstrating the distribution of iodine. And you can see that this lesion, which was hyperdense to fluid on the standard image, contains no iodine on our iodine image. So again here, with a single post-contrast acquisition, I can definitively conclude that there is no iodine in this lesion. It is a benign lesion, and I do not need to do subsequent imaging by ultrasound, CT, or MRI to figure out what this is. This is one of my favorite applications for dual energy CT. Here's an example of how this can be used in GI bleeding. Both of these patients, as you'll see, have bright material within the bowel loops, and our job now is to determine which of these is iodine, which of these is active extravasation from a GI bleed into the bowel lumen. So here we go. We have our virtual non-contrast image where this material has disappeared. It is present on the iodine map. This is definitively characterizing this bright material as iodine. I don't need a true non-contrast image. I don't need a delayed phase. This is iodine. This is a GI bleed. What about the bottom case? Well, here I still see this on a virtual non-contrast, and I do not see it in color on my iodine map. This is definitively not iodine. This is bismuth that the patient took for their abdominal discomfort when they were at home before they came into the hospital. So with a single post-contrast acquisition, I can characterize the presence or absence of iodine. And we can also do quantification. This is a little bit busy, but this is the region of interest tool on the Siemens machine. And what you see here is 163 Hounsfield units on our mixed or conventional image. It mixes the data from both the high and the low energy. That gets decomposed into 124 Hounsfield units due to iodine or contrast media. And what's left is 40 Hounsfield units from the virtual non-contrast image. What they also give us is a calculated iodine density or concentration in milligrams per milliliter. Here's an example on a GE system. In their system, the quantification is a little bit different, but we again have one of these hyperdense lesions. We can see that this decomposes into a certain concentration of iodine and a certain concentration of water. So a little bit of a different understanding is needed to interpret these images between the vendors, but the effect is the same. Here we have a case of pancreatitis done on our machine. You can see, I hope, some subtle decrease in attenuation in the pancreatic head compared to the uncinate process. We can make that difference in iodine enhancement much more visible by using an iodine overlay image. We can see there's less color here than here. We can do the same thing at a low KEV image because, as I mentioned, low KEV gives us better visualization of iodine content, and we can better see differences in iodine content on that basis. And if we wish, we can do quantification and put regions of interest in these areas where we see differences in iodine concentration between the area of early necrosis and the normal parenchyma. The other thing that we can do very nicely is differentiate iodine from other materials like calcium. So here we have a patient scanned for another reason who has had a previous stent graft repair of an abdominal aortic aneurysm, and we see some bright material in the lumen. We want to know, is this an endoleak or is this calcification? So we do our traditional images. We see that this material is bright on the iodine image, disappears on the virtual non-contrast. This is definitively iodine. This is definitively iodine, diagnosed on a single post-contrast scan. On the other hand, this material along the wall here is present on both the iodine overlay and the virtual non-contrast image. This is calcium, which, as I mentioned, shows up in both sets of images because it is not one of the three materials that we selected in our decomposition. So let me show you a little bit better why this works. I showed you three material decomposition in this way, but calcium actually behaves like this. It has a more shallow slope of its Hounsfield unit change as we increase concentration. But what happens is we've still asked the algorithm to decompose this into iodine and virtual non-contrast. So we've taken this increase in attenuation and we have artificially divided it about half and half due to iodine content and due to virtual non-contrast content, which is why the spine and the calcification along the wall here appears on both sets of images. We can use similar principles to actually intentionally make other algorithms in dual energy CT. Here's an example in the brain where we have a traditional three material decomposition scheme. We can intentionally change that slope of iodine to the smaller slope of calcium, and now instead of creating an iodine image and a virtual non-iodine image, we can create a calcium image and a virtual non-calcium image. And the place we love to use this is to differentiate hemorrhage from calcification on non-contrast head CT. So here we have an example. The orange here represents calcium. It's the calcification within the choroid plexus. You see a little bit from the pineal gland here. That's that bit. And this material is bright, but not orange. So this is hemorrhage. This does not contain calcification. And from this image, I can differentiate calcium from hemorrhage, which can be very useful, as I'll show you a little bit later. The other application for these calcium techniques is particularly in musculoskeletal uses, where typically on CT, here we have a CT scan of a hip, and you can see there's a very subtle minimally displaced fracture through the greater trochanter. If we do an MRI, a stir image, we can see the bone marrow edema pattern is actually much more extensive and suggests an intertrochanteric fracture. This is the CT bone marrow edema. So what we've done here is we've done a virtual non-calcium technique to remove the annoying high attenuation from the bony trabeculae. And if we remove that confounding attenuation, we can now look directly at the underlying attenuation of the marrow space itself, which we now color code in green to make it more visible. So this allows us to see through the calcified trabeculae in order to tell what's happening underneath. And this is a very helpful technique in trauma, particularly for the large joints, hips and knees. It doesn't work so well in the spine at this point for a variety of reasons. All right. The other thing we can do now, rather than these decomposition techniques, is we can do much more crude characterization techniques. So here's an example where we want to do bone removal. And I've shown you these different slopes of iodine and calcium here. We can artificially draw a separation line between these materials, and everything that's located here we can characterize as an iodine pixel, and everything down here as a bone pixel. And that means that if we have a case like this where we have a MIP image that's not very helpful here because we're not able to see the vertebral arteries due to all of the confounding bone, we can simply null out all of the voxels that behave like bone, and we can create MIP images that look like this. We can do the same thing for kidney stones. Calcium-based stones live up here, uric acid-based stones here. We can draw a separation line, and we can color code calcium-based stones in blue and uric acid stones in red, which can be helpful because these uric acid stones can often be dissolved with medications that alkalinize the urine, whereas these cannot. Here's an example, another uric acid example in gout. We see some bony erosions here and maybe something a little bit funny here. We suspect this might be gout. We can do a dual energy CT, and now we're color coding in green everything that represents uric acid. So not only can we see the tophus, the uric acid deposition here that was visible as an erosion, but we can also see a lot of soft tissue deposition that we have no way to see on the X-ray. And so this can be a very helpful technique. Our rheumatologists love this for non-invasive diagnosis of uric acid in place of joint aspiration, and also for monitoring treatment response after therapy. You can see the volume of these tophi decrease over time. So now that I've gone through the technique, I see I'm running out of time, but I'm very quickly going to go through some of the ways in which I think dual energy CT can be helpful. Detection. One of the things we like to do for our non-contrast head CTs is a bone subtraction technique. This makes it very easy to see these very subtle subdural hematomas that are otherwise so easily obscured by the overlying bone. Here, if you're very astute, you might notice a slight decrease in attenuation at the left ventricular apex. Well, here on an iodine image, you can see that there's no iodine here. This is actually a patient who had an acute LAD occlusion, a myocardial infarction here. This is a patient where we have a conventional CT scan. Does anybody see gallstones? I hope not, because I can't see these gallstones, but they're there. Here they are on ultrasound and MRI. If we use virtual monochromatic imaging at low KEV or at high, we can see them stand out much better against the surrounding bile because these contain cholesterol, which behaves very much like fat. This is a trauma scan, not a great injection of the spleen. Does that mean I have 5 minutes left? Okay, thank you. Not a great injection, but if we go to low KEV, we can see much better this laceration through the spleen, very difficult to see here. Another example of trauma, this is a patient clearly with a subcapsular hematoma with a laceration at the upper pole. And with our iodine image, we can see not only we can confirm that there's no active extravasation of contrast into this hematoma, but we can also better see the areas of laceration in the renal parenchyma. Characterization. I already showed you our ability to differentiate different types of kidney stones using this information. Here's another example. We see a hyperdense lesion. This, without a doubt, contains iodine, as we can see here on our color-coded iodine image. In contrast, we see this lesion that's clearly hyperdense to simple fluid in the collecting system. In this case, we see no color-coded iodine. This is a benign hyperdense cyst that does not require any further workup. Here's another trauma case. We can see that there's clearly something wrong with this loop of bowel. If we do our iodine images here, we can see that this has been devascularized. There is no enhancement of this portion of the bowel. This was a serosal avulsion. This needed to be resected at surgery. Here's a bright spot on a trauma scan. What is this? Is it calcification? Is it contrast extravasation? Here we go. We have it disappears as usual on our virtual non-contrast. It is clearly present on iodine. Even without any additional phases of imaging, we know definitively that this is active extravasation of contrast into this mesenteric hematoma. Here's another trauma case. We see some bright material here. We can confirm with dual energy CT that this is bland hematoma, no active extravasation. And these can have differences in management. This is a case where we have clearly an acetabular fracture here, and we have a lot of bright spots on this image. Well, let's look at this one. This one is bright on our iodine image and disappears on our virtual non-contrast, so we all know by now what this is. This is iodine extravasation around this fracture. This spot is bright on both our iodine image and our virtual non-contrast image. This is a calcified fracture fragment, so we can easily differentiate iodine from calcium. I showed you the bone marrow edema case, very helpful for further characterizing our fractures and better defining their extent. Ease of interpretation. I don't know about you, but whenever I see one of these cases, I groan because I hate reading polycystic kidney cases. These are very difficult on multi-phase CT or MRI. We traditionally have a non-contrast scan and a post-contrast scan, and they're never perfectly registered. We often have to place a region of interest and try to match the location in another image. Here, with dual energy CT, the iodine information is inherently co-registered perfectly with the non-contrast imaging, and you can see that we have enhancement within these lesions. These are enhancing masses, whereas this patient, this is a non-enhancing hyperdense cyst. This makes it so much easier to read these types of cases. We have shown this both with a reduction in interpretation time for these cases, but more importantly, I think, with an improvement in confidence in reading these cases, where we found in red here that using our iodine images, our dual energy images, we had a much higher proportion of cases with the highest certainty scale, either enhancement definitely absent or enhancement definitely present, compared to conventional multi-phase renal mass protocol imaging. Prognostication. Here, I think everyone here sees these pulmonary emboli, but what you cannot tell is the impact on the iodine distribution in the lungs. So to me, a lot of the work in pulmonary embolus CT that's most exciting is the ability to infer how serious the PE is based on how much the iodine distribution is diminished. Another area, this is a small loop of bowel and a closed loop bowel obstruction. But what we can tell with our iodine image is that compared to the adjacent bowel, which shows enhancement, this one shows no enhancement. This is almost certainly dead or dying bowel that needs to be removed. Protocol robustness. The point here is that we rarely know ahead of time, at least in the ER, we rarely know what we're going to find before we scan the patient. So here's an example. This was unexpected to see this bright material that I showed you before. We can now troubleshoot it. We can figure it out without further imaging. Here's another case, a patient who had previously had a peripancreatic pseudoaneurysm coiled, and now we have this dense material here that we can confirm to be iodine based on the dual energy imaging, again from a single post-contrast scan. Length of stay, here's an example of the calcium versus hemorrhage application I showed you. Traditionally, we see a trauma patient come in with this bright spot in their brain. We don't know whether this is pre-existing calcification or hemorrhage related to trauma. So what do? We wait 6 hours and we image them again. It looks exactly the same. We still don't know if it's calcification or hemorrhage related to trauma, but at least it hasn't changed, so we feel reasonably comfortable to let the patient go home. Well, with dual energy CT, we can see with our color-coded calcium overlay that this is orange. This is calcification. There is nothing on the virtual non-calcium image, so we can much more confidently conclude that this is not hemorrhage. We don't even need to keep the patient for that 6-hour follow-up scan, and we can let them go with much more confidence that this is a benign pre-existing finding. Radiation dose reduction. I've showed you this example. Our GI bleeding protocol now, instead of being a 3-phase protocol with a non-contrast, an arterial, and a venous phase, we absolutely have eliminated the non-contrast scan because we can use a virtual non-contrast scan. And in fact, we're very close to getting rid of the arterial phase scan as well, because if we can definitively characterize this as intraluminal iodine content, we really don't need more than 1 phase. Finally, utilization. I mentioned to you the renal lesion characterization. This is clearly non-enhancing. This is clearly an enhancing mass. Well, we found that a large proportion of our patients in the ED come in with incidental lesions that are hyperdense to fluid, and traditionally we would be required to recommend follow-up imaging. But at least half of these we can convincingly conclude are benign based on our dual energy CT. To do this, we have to perform dual energy CT routinely in everybody because we don't know ahead of time which patients will have these findings. But the impact is that we can greatly reduce patient anxiety, resource allocation, cost, and radiation exposure by using these techniques. We can also use this for adrenal nodules by showing a virtual non-contrast Hounsfield unit less than a 10 HU threshold. So I've tried to step through a variety of areas in which I think dual energy CT can add value. And now perhaps we have time for 1 or 2 questions, even though I've gone slightly over time. Thank you.